5 or 6 years ago when UCSF finally took a hard look at itself, although we had plenty of areas of spectacular quality, our system of care as a whole was not as safe as it should be. And it was at that point that we embarked on a new effort, a new view, a new culture to increase safety and quality at UCSF and at UCSF Medical Center.
If we can't get that drug, the right drug to the right patient at the right dose at the right time, if that breaks down, then the rest is for naught.
When our previous Chief Medical Officer, Ernie Ring, started, he met with me and asked what our infection rate was. He was aware this is an important outcome in the ICUs. And I had to tell him I didn't know because I didn't have the resources to actually even measure those infections. And so Ernie was willing to provide the resources where we could have some ICU nurses essentially reassigned to do surveillance for these infections. About that time, we also started some training programs for the residents that worked in the ICU that included some hands-on training, some simulation as well, and started to measure our infection rates. And I would say that was really the landmark event where we actually had data.
Central line infections unfortunately continued to be a problem. And at the time that I arrived, we actually didn't even know how large a problem. We weren't collecting the data that would be necessary for us to measure that. As far as I could tell, just anecdotally, it seemed like almost every week we had another patient with a central line infection.
It was seeing real data, comparing UCSF Medical Center to other prestigious medical centers in the country and showing that we were not doing as well as we thought we were doing, I think was a very powerful event for us and had been a real driving force ever since.
So we started doing root cause analyses here, I'd say about 7 years ago. I think in the beginning, we were a little bit haphazard about it. We kind of patched one together when a bad error happened. And starting about 3 years ago, I guess, we reorganized the root cause analysis process to the point that it is now, I believe, the best I've seen in the country.
In a multidisciplinary way, the nursing staff were very important, the infection control group, pediatric infectious disease, and physicians and pharmacy all came together to try to tackle this problem. And the first thing that we needed to do, and that was done, was to collect the data in terms of the number of line days and actually the numbers and types of infection. And the nursing staff and infection control were absolutely crucial to getting this information. Subsequently, with further education and emphasis on hand hygiene, at looking at everything that had to do with our practice in terms of delivery of care, we were able to cut down from what was an original rate when we started measuring, thus meeting both our own internal goal as well as at the same time meeting the hospital goals.
One of our biggest sources of medication errors is human error. Automation is key. Now, granted, we're driving automation with the human component, but the steps along the way are now going to be automated and much safer. One of the most significant changes that we've made is we've brought in more pharmacy oversight for the preparation of the actual doses and ensuring the safe storage of them.
Getting to where we are now has created a substantially different kind of work. It's really teamwork. It's all of the people who are involved in the care of a type of patient or even might be involved in those types of patients. And there are many of the people you'd think, nurses, pharmacists, physicians, but a lot of people you wouldn't necessarily think. Environmental services, technicians, medical records, information technology. We've had to bring to the table all of those professionals to really achieve the level of safety that we have in certain areas. It's that teamwork approach, that view that this type of thing takes a team, I think is also one of those core requirements for getting your level of safety and quality to be the highest it can possibly be.
One thing we've done with our root cause analysis is give it a fixed time period, meaning that we meet generally every Wednesday from 9 to 11. It's a standing meeting. The reason I think that's so important is in the beginning we said, why should we have a standing meeting? We'll have one when something nasty happens. But after a while you realize there are enough bad things that happen that you're better off having a fixed time interval and having a fixed time actually lowered our threshold for using that process because we knew we would have a group of people together. We would sometimes say that was a really bad near miss. Nobody got harmed, but we got lucky. Let's go ahead and analyze it using this method and using the committees. We have about 10 frontline caregivers. Anyone who is involved in the case comes to the meeting. And they're quite naturally scared. They've just gotten a call from the Office of the Chief Medical Officer to come and talk about something that was bad, that happened, maybe a patient's death. I mean, sometimes these are terrible things. The person who runs the meeting, usually our Associate Chief Medical Officer, Adrian Green, begins the meeting by saying, this is about fixing systems, not pointing fingers. We need all of you here because we need your wisdom. We need to learn what happened from your perspective. At the end of the meeting, we'll come up with some ideas about ways of fixing this. And one of the things she sometimes will do is say to them, tell us why this might not work in your world. You know, we know patient safety, we know systems, but we don't know what life is like on the labor and delivery suite at 1 a.m. You do, so you tell us why this might or might not work.
So we've gotten, I think, to that place. We've done a huge amount of work in individual areas around medication safety, around preventing hospital-acquired infections and hospital-acquired injuries, improving communication, defining real outcomes, just holding ourselves accountable to measuring something and putting resources into improving the results of the measurement. So because of that really cultural change, I think we are now poised to take quality and safety to an extremely high level. We'd like to be the safest hospital in the world.
Please welcome to the stage Chief Medical Officer, UCSF Medical Center and UCSF Benioff Children's Hospital, Dr. Josh Adler.
Thank you, everyone. Thank you for watching our video. It still gives me great pride. UCSF, I don't think, is the safest hospital in the world, but we are desperately trying to become that place. Wherever that is, we know that it probably means 0 preventable deaths. And we're not there yet, but we're making great progress. Well, it's a delight and honor to be part of this conference and to be part of the patient safety movement. And at long last, we're going to be able to talk about safety culture. But in fact, we've been talking about safety culture for the whole conference. It hasn't actually been called out that way, but there have been many, many examples. In fact, in the panels we saw just this morning were some shining examples of high safety culture. So what we're going to do in this session is try to delve a little bit deeper into safety culture, specifically defining what it is, why it's important, and hopefully ways in which we can all bring our organizations to a higher level of safety culture. So why focus on it? Dr. Classen sort of hammered this point home several times, but it bears repeating. 15 years of very dedicated work to improve safety in America, and in many cases across the globe, and yet our degree of improvement has been quite modest. So we have to do something different. Most of what we've done in safety has focused on tools and processes. Familiar, tools and processes. A checklist, robotic pharmacy, barcode administration, and education. The problem is that the implementation of any tool or any process has to be couched within a system, within a culture, within a set of beliefs. And if those are not prepared for this new piece of technology or this particular process, or it doesn't fit well, it doesn't necessarily get used. Let's look at some examples. So the checklist, let's look at the pre-surgical checklist, a terrific tool that should help reduce errors that occur with procedures in the operating room. And if any of you have watched the use of a checklist in different organizations, you could see on one end of the spectrum a complete silence, everyone listening, everyone paying attention, a diligent following of the components of the checklist with everybody clearly paying attention to why they're doing it. because they see the checklist as a tool to help them do what they're already trying to do, to keep the patient safe. So that's one type of example. In another organization, you'll see that the checklist is being used. Checks are being put on a piece of paper, on an electronic chart, over in the corner of the operating room. One person's kind of going through it by themselves. Everybody else is scurrying around getting ready for the case. They both use a checklist, but clearly only one of those is going to make a difference. If we look at robotic pharmacy, a great innovation in technology to markedly reduce the human error, and we've had great experience with it at our institution. But it also has to be couched in the culture of the organization. If the organization says we no longer have to worry about safety because we've got this technology, and they stop paying attention, that doesn't work either. Then you see a whole new set of errors. The point is that the technology has to be seen as a way to help us do what we want to do anyway, not replace something that we didn't want to pay attention to. Barcode med administration, barcode breast milk administration, same kind of thing. It only works if people use it. And then I just want to say a word about education. Education shows up on the list of activities to make improvements in virtually every patient safety plan, quality improvement plan. But it's a very weak intervention. Education by itself is extremely weak and can't be seen as the end. And again, an organization with a high safety culture will see education as a weak tool that is needed but doesn't get the job done. So improvements have been inconsistent, variably sustained, sometimes misdirected, and susceptible to workarounds. And I just want to say a word about workarounds. The workaround is the thing that kills all these great technologies and processes. And the reason they occur is that they haven't been thoroughly thought out, that they've been dropped into an environment where it's really inconvenient to use that process, or very inconvenient to use that technology, or we haven't been given all of the tools we need. And healthcare workers are smart people. They'll find a way around it. You've probably heard the stories of barcode med administration where a nurse will actually take the barcodes of all of the patients on their unit, tape them to the jacket, go to the drug cabinet, take out all the pills, barcode the pill, barcode the jacket, barcode the pill, barcode the jacket, barcode the pill, put all the pills in the pocket, go to the bedside. That's barcoded med administration. It just doesn't make anybody safer. And that's because the underlying culture didn't take the steps to say the reason we're doing this is to keep people safe and help you do your job better, and put in whatever systems were needed to make sure that it was actually possible to follow the rules. So let's talk about culture for just a minute. What do we really mean when we say culture? Well, this is a nice diagram that I think describes a lot of it, and in particular what's important is what's below the line. So organizational structure, official processes, stated values, vision and strategy, that's what's all on the surface, that's what's on websites, that's what's in your official annual report documents. But the most powerful parts of culture are actually below the surface. Symbols, stories of what happened 5 years ago, shared assumptions, unwritten rules of behavior, norms of behavior, and sort of the secret values. So that's the part of culture we have to pay attention to if we want safety to really get to a high level. Another way of looking at it is the way we do things around here. That's a classic experience of a new employee in an organization where they come in, they have a view of what they think the organization's about, and their very first day it doesn't go that way, and they ask, well, I thought we were supposed to double check on this for medications. Like, well, that's not the way we do things around here. That's culture. And patient safety culture is no different. This cartoon shows a classic safety culture. There's a poor patient in the bed, there's a senior doctor in front and a bunch of junior folks in behind, and he says, when we want your opinion, we'll give it to you. Well, if you're one of those junior folks behind, you get a very powerful signal about the culture of your place from just that one statement. That you may say patient-centered care on your banner, on your website, but this is what it actually looks like in practice in this organization. So patient safety culture, sort of thought about a little more rigorously, one aspect of an organization's culture. It's the shared values and beliefs and norms. It provides cues to all of the employees about the relative priority of safety versus other institutional priorities, such as efficiency, financial health, etc., and informs perceptions about what is praised and what is punished. It's these last two bullets that really make the difference in many cases. If you imagine every single safety event, or most safety events, you hear the description, it usually starts with, it was a really busy day in the ED, or we were sort of understaffed on the unit, or there was a shortage of X, Y, or Z medication, or the PACU was packed with patients and we were trying to move them up. That's always the case. The question is, under those circumstances, what is the instinct of the employees? Is it to say, I think I will do better in this organization if I do what's right for this patient, follow the procedures to keep everybody safe, even though I know that it's increasing the time it'll take to get this patient up to the ward, or is prolonging the length of stay the patient has in the emergency department. And those are the things that underlie actual behavior. When you're stressed and you have a decision between one of two things and they seem very close at the time, do we make the right decision? So let me just say one quick word, patient safety, culture, and outcomes. There's actually emerging evidence that there's a relationship, a scientific relationship, high safety culture, better outcomes. And in fact, there are specific interventions that can be used to improve safety culture, and we'll hear about those in a minute with the panel. So let me just say on my last thought, Dr. Classen challenged us earlier on. He said, how many of you, if you had an SPD technician in your organization who knew something was wrong with sterilization, how many of you were sure that that technician would inform his or her supervisor? And it was, a low number, 5%, 3%. I would say that true high reliability is even a higher bar, and it isn't when that employee knows something's wrong, it's when that employee isn't sure that it's right. In that circumstance, can you say in your organization that that employee who's not sure it's right will raise their hand and say, I think we have to stop here a second because I'm not sure it's right? That's a very high bar. I don't think we have that bar in my organization yet, but that's what we're trying to get to. So, without further ado, let me introduce our panelists. So first is Laura Townsend, who's the co-founder and president of the Louise Batz Patient Safety Foundation. Second is Marty Scott, who's vice president of Brenner Children's Hospital and chief patient safety officer at Wake Forest Baptist Health. Next, Coleen Smith, who is the Director of High Reliability Initiatives for the Joint Commission Center on Transforming Healthcare. Next up, Dr. Stephen Muething, who's the Vice President for Safety at the James Anderson Center at Cincinnati Children's Hospital. Next up, Jack Garon, who's the Chief Medical Officer in the Sinai Health System in Chicago. Rick Boothman, who's the Executive Director of Clinical Safety at the University of Michigan Health System. And finally, Dr. David Mayer, Vice President for Quality and Safety at MedStar Health. All right. Please be seated, group. So as you can see, we have a somewhat large panel. And as I've learned over the last couple of days getting to know them, they all have a lot to say. And there is a lot to say. So we're going to do our best to cover as much territory as we possibly can. And whatever we miss, I think, can be handled in the Q&A section. So Laura, let me start with you. As a patient advocate and family member whose family has suffered a tragedy due to a preventable error, could you tell us the story of your mother and how it relates to a culture of safety?
Yes, thank you for having me here today. We're very honored to be here. It was a little over 4 years ago, 2 days after Easter, my mom had made the decision to have a routine knee surgery. Everybody said it was routine. It was not going to be any big deal. She'd be in and out of the hospital in 3 days. And we really felt like it was routine because a couple months before that, my dad had had quintuple bypass surgery. And that, was the big one. And we have 5 doctors in our family. And of course, they all came in and descended on my dad. Nobody left his side. And so this was going to be a walk in the park. And so I remember I came down from Austin the night before to be with my mom, and we were. It was our last kind of evening together, and before her surgery, and she had all of her paperwork together sitting there, and we were watching. We loved to watch 24. We loved to see how Jack Bauer was going to save the world in 24 hours. It was great. And but she was ready to go. She was one of the most thorough people I'd ever had met. She always dotted every I and crossed every T, and she was bound and determined to be up and ready to go for the birth of her 4th grandchild that was coming in June. And so she went to the hospital the next day, and my aunt and myself and my father were with her. And I think as a family member and a patient, you always feel like if I can just make it, if your loved one can just make it through the surgery, they'll be okay. And so we went to the waiting room. And she was there for about an hour and a half, and the doctor came out, and he was just thrilled to death. He said, she's got a beautiful new knee. She's ready to go. She'll be ready to go in 3 days, and we're just so pleased of how she did. And so we were just, this huge sigh of relief came on, and we're just like, thank goodness. And, the coast is clear from here on out. And so she went down to the orthopedic unit, and she was on a PCA pump, getting 2 milligrams of morphine. And around 6 o'clock that night, she started to feel a little nauseated. And so they gave her a medication called Visceral, and which I didn't know what that was, but apparently it's an antiquated sort of form to use for nausea. And so it was about 10 o'clock, 10:30, and I was talking to the nurse, who was wonderful. I probably spent 25 minutes, 30 minutes, asking her all these questions. I always laugh. My aunt and my dad were with me. I always laugh. My aunt, I said, I think she picked the wrong profession. She should have been in the CIA because she will break you down with questions. She will break you down. And I asked her so many. And we asked how the night was going to go for my mom. And they said at midnight, my mom was scheduled to get Visceral, morphine, and Demerol. And I was like, wow, that seems like a lot of medication for someone who, maybe took nothing more than an Advil in her lifetime. And the last time she was in the hospital was when she had me 35 years before that. And so I said, well, they asked her, I said, I don't think she needs all of that. And they said, well, what type of pain are you in, Louise? And she goes, well, I don't know, how do I rate it? They said, well, from 1 to 10. She goes, I don't even know how to scale that. And she's like, well, do you think you're having a baby? And she's like, oh, I'm fine, and this is nothing. And so we decided, please, just give her the morphine if she needs it, but she doesn't need the Visceral, the Demerol anymore. And so then the nurse told us to please go home because she needed to get her rest, and because she had to be up at 4:45 the next morning. And so my dad and I went home, and I remember sitting with him. I think it was probably the first time my dad had been without my mom in the house in probably 45 years. I mean, they were always together. And we got a call about 3 o'clock in the morning that my mom was having trouble breathing, and to please come to the hospital. And so I got panicked, of course, and I called my uncle, my mom's brother, who's an OB-GYN, and he said, don't worry about it. I'm sure she'll be fine. They'll just take her to the telemetry floor. No big deal. And I called my brother in Dallas, who's a radiologist, and he started to panic. He's like, oh no, did she have an embolism or something like that? And so I get to the hospital, and I'll never forget. There's one thing that hospitals need to start working on changing, which I know some of them have, those long white hallways. They're just awful. And there was a security guard outside the door, and my heart started to sort of drop. And I ran. I left my dad behind, and I looked in, and I thought she was already dead. She was just lifeless on the bed, and they were just using the handheld oxygen with her. And I was like, wow. It was like 20,000 knives had just gone through my body. What happened? I just gave her a kiss. a few hours ago, and she had this smile on her face. She always had a smile on her face no matter what. And now this. And my mom had been given the Demerol, morphine, and Visceral at 12 o'clock. And she went into respiratory depression, and she suffered a anoxic brain injury. And she was in ICU for 11 days. And it didn't take us very long to figure out what happened, because we have 5 doctors in our family, and we grew up in the medical community of San Antonio for over 100 years, and we must have had over 100 people, coming into the hospital room to see my mom, because she was so loved, and so many doctors coming in to see my mom, and they're all saying, this should never have happened. What happened? It should never have happened. This was preventable medical error. And I go, what is that? I had no idea. I had never heard it in my whole life. And we grew up in the medical community, and I don't think we'd ever talked about it as a family ever. And I started doing some research, because that's what I did. I grew up in the sporting world. Sports were my passion. I worked for the San Antonio Sports Foundation for 10 years, raising money for our youth programs. And I was trying to figure out what these are. What is a preventable medical error? And I thought, are we the most unlucky people in the world? Does this happen just a little bit? Or does this happen to a lot of people? And I was so shocked. I couldn't believe when I started seeing the stats that, it's the 3rd leading cause of death in this country behind heart disease and cancer. And how did I not know about it? And how did we not know about it, our family? We never talked about it. After 11 days of my mom being in ICU, she was not going to make it. We had to take her off life support. And that is not like it is in the movies. It is so much worse. I held my mom's hand, and I begged her to go on. I lied. I said that we would be okay. My brother couldn't even be in the room. He had to walk away, and he came back at the end. My dad was at the foot of the bed, a broken man. My uncle, he was in the window. My sister-in-law, who was a urologist and 8 months pregnant, had her head down at the foot of the bed. 30 minutes later, she was gone. We were defeated. But that night, we wrote the mission for the Louise Batz Patient Safety Foundation. My mom's life was not going to end there. That was not the end of her story. She always taught me to, when things were down, and if I was down and I was frustrated with something, she's like, you know what? Don't worry about it. We're going to keep work it out. We're going to have hope, and we're going to work it out together. And so that's what we did. And it was amazing. It's been an amazing journey the past 4 years. Because after that happened, the medical community in San Antonio, they all embraced us, and we all came together, and the hospital was great. And the CMO of the hospital was actually a colleague of my uncle's. She was an OB-GYN, and she called me a week later and said, we need to fix this. We need to help and not make sure that this doesn't happen to other families. And so the first thing that we did was we all came together to figure out why did this happen. And we really feel like there was 3 things that really tie into the culture. And the first was it was a lack of knowledge. I asked 1,000 questions that day, and I just didn't get lucky and ask the right one. And you don't want to be lucky, going to the hospital in hopes that you're going to ask the right question. The second thing was a lack of technology. My mom was given, Demerol, morphine, Visceral, and she didn't have any type of monitoring on her. And I always say that it's kind of like they put my mom in a car going 200 miles per hour without a seatbelt and saying good luck. And we all know what happens when you don't do that. And I was so glad that Mr. Moreau from St. Joseph's Hospital is here, because I got to thank him yesterday, because after this happened to my mom, I think I did a 100-page research paper on PCA safety. And I went and researched other hospitals that continuously monitor their patients, because at this hospital it was every 4 hours. That was their standard of care at the time. My mom was dead at 3 hours and 45 minutes into that shift of monitoring her. And I was so excited that St. Joseph's continuously monitored their patients, and I took it to all the hospitals in San Antonio and said, look what they do. There's no excuse why we can't do that here. And the third thing was a lack of teamwork. I always say that we had a great family, a great nurse, and a great doctor, but great players don't make a great team. There is no I in team. And a few years ago, it was great. I felt like Magic Johnson quoted me because it was when LeBron James and the Miami Heat were playing for their first NBA championship. And they lost to the Dallas Mavericks. And Magic Johnson said, 3 players don't make a good team. They lost to a great team this year. And I was like, hey, all right, somebody's quoting me. That's awesome. So, and that really, it makes all the difference. And what I've been hearing, the past couple days of all the hard work that you guys are doing. And my mom, oh my gosh, we took such pride in the doctors in our family. And she took such pride in the doctors in our family. What you do every day is amazing. You save lives every day. I just wish that we could have helped you. I wish I could be part of that team. Because you are not alone. We want to help. And I think the most important thing is if you want to get to zero, if we want to get to zero by 2020, it can't just be the doctors and the nurses and the clinicians and the hospital staff. You have to include us. Because nobody knew my mom like me and my dad. We could be that vital player on your team. I don't want to be the A team. I just want to be the B team. That I could have come and make that 3-point play at the end, or I could have come and make that field goal kick, to win the game, because I could have helped, but I was sent home, and I'll always wish I had stayed. But I thank you, and this is where I feel like we can really improve, and this is what the culture of safety means to me, is really creating that awareness out in the community, because we all know it happens, but still there's such a mass population that they don't.
Laura, thank you so much for sharing that story.
Thanks.
Coleen, Laura mentioned a number of cultural issues that clearly contributed to this error and her mother's death. Perhaps you can talk about why the Joint Commission has identified culture as such an important area for hospitals to specifically address.
Absolutely. So, in addition to being a high reliability initiatives director and being with the center for the last 3 years, my first 7 years at the Joint Commission were spent in the Sentinel Event Unit. And in that unit, as a nurse, as a clinician, I reviewed hundreds and hundreds of root cause analyses about bad things happening to people. And throughout these root cause analyses, I kept seeing the lack of people speaking up. The people knew that there was something bad going on, but they were intimidated or they were scared or they didn't think it was their place. And if just one of those people had spoken up, many, many of those events wouldn't have occurred. So we've known for a long time that if people don't feel empowered, if they feel afraid, if they don't even have the knowledge of what constitutes an unsafe condition, then bad things are going to keep happening. And so that knowledge, and when Dr. Classen came on board 5 years ago, his vision for those 3 things of leadership, safety culture, and robust process improvement, transforming healthcare into a high reliability industry, just really started to resonate.
Gotcha. So, Rick, we've heard the word transparency several times during this conference, but we haven't really delved into how transparency actually affects the culture of safety and outcomes for patients. Maybe you can tell us about that.
Sure. The culture of safety is not possible without transparency. You cannot fix a problem if you're not willing to first identify it, acknowledge it as a problem, and then commit to doing something about it, including talking about it. So transparency in the broad sense was understood by Alcoholics Anonymous, right? In the 20s. You have to admit that you're an alcoholic before you can get off the dime. The concept in our world is broader than that. It's not just sharing the sad stories or the dirty clinical laundry. It's the willingness to call out perverse incentives. It's the willingness to identify when somebody might have self-interest in the way we do business rather than putting the global health of our patients ahead of that. It's the insistence on seeing things from the patient's perspective. We are all changed when we reach down and ask to understand, and I think that's the part of transparency that is really important to understand. There is an urgency to it. Patience, when lives are at stake, is not a virtue. And we need to get on with it, but we need to get on with it in a respectful and a sensible way. Because healthcare is, you know, I understand the connections with Toyota and with the airline industry, but it's a hell of a lot more personal than building a Toyota. And it's a lot more ambiguous than, safety is a lot more ambiguous than it is in the airline industry. Patients are not 747s. They don't come standardized like that. When a neonatologist whisks away a newborn baby with neurologic impairments, it doesn't necessarily mean that somebody did something wrong. So to understand and have the commitment to really understand and then call it out when you see it is what's really important. But it needs to be done not recklessly. It needs to be done in a very respectful way, because transparency will change behaviors, sometimes for the worse if we're not careful.
Steve, I wonder if, I'm going out of order now. I wonder if you could pick up on the transparency theme a little bit and some of what you've done at Cincinnati Children's to sort of address the transparency, particularly given the fact that there's fear inside of provider organizations about being excessively transparent.
Sure, Josh. Of course there's fear. There's fear not just from the clinicians, there's organizational fear. You know, I think along our journey to high reliability, I think we made a decision a long time ago that we couldn't wait till we were ready for transparency. And I think transparency is one of those things where you just have to start before you're ready. You're never going to be ready, and you just got to do it. And then, you know, along the way, we've done so many things, and it relates to the high reliability concepts of preoccupation with failure. You know, at the beginning, it was demonstrating how many days it's been since our last serious safety event or our last lost work time injury. But what that has caused people to now do is that on a daily basis now, the organization, we talk about the events of harm, that not those that occurred last month or not a rate. We talk about who got injured yesterday and what are we learning about it. And that would not have happened without transparency. And so I think it takes that organizational commitment, and I totally agree with Rick, is that if you're truly committed to zero, you're not going to get there without transparency, so just get over it and get started.
Transparency, just get over it. All right, that's a good tagline. So changing gears a little bit, Jack, we actually heard a lot about leadership from Chuck a few minutes ago, and actually Sharon gave a great example of leadership in the earlier panel. Can you speak about the role of leadership, both boards and the C-suite, in really furthering the safety mission?
Yeah, the board, for us, and we're completely transparent with the board, so we take all of our root cause analyses in excruciating detail, and we present them to the board with, you know, the whole timeline, what we found were the problems, what we proposed as the solutions, and how we generalize that to other places in the organization. And the board has its own culture. The executive team has its own culture. And over time, so when we first started doing this, there's sort of the gee whiz thing, and the board listens to it. And over time, the board we now have all these shared stories, and you know, there's a shared culture there. And the board says, well, you know, didn't we hear this before? And you know, what are you doing this time? And have you thought about this? And they get more and more comfortable with us and with and not comfortable with the events, but with pushing back and with asking questions and knowing, you know, wanting to know more and wanting to engage more fully. So over time, their culture changes in the way that we hope that ours does, I think. But, you know, we're very transparent with them, and in turn, they interact with us in a very engaged way.
So Marty, I made some initial comments about what culture is and the fact that culture is so powerful, but if you want to try to change it, if you want to try to alter it, you come up against the fact that the culture in orthopedics is different than the culture in neonatology, the culture in ambulatory surgery. How do you organizationally approach those differences of local culture?
Yeah, so what I've discovered is this idea of tight, loose, tight. And it's the idea that the senior leadership sets these tight expectations around safety is our priority. What we want you to do is create a safe day every time you encounter a patient. So you take those down to that unit level, those tight expectations. But at that unit level, they're the expert in their microsystem. And so then you let them identify what are your high-risk situations. And we know that in healthcare we have high-risk situations all over the place. And the hallmark of a highly reliable organization is, in spite of those high-risk situations, they can deploy low-risk behaviors to avoid an error or else to mitigate and capture and contain an error. So you ask them, find your high-risk situations, and we're going to train you on these highly reliable error prevention tools, and you figure out which tools are going to work in your high-risk situations. But then on the back end, you come back with another tight expectation of, we want to see no episodes of harm from your unit. So this idea of a tight set of expectations, but respecting the commitment and the strengths and the skills of those units to develop their own systems to identify high-risk situations, identify those triggers, use those tools, create those habits, and then just have those tight expectations that you're measuring on the back end.
So Dave, do you think that same strategy works in a multi-hospital system where you're talking about regional differences in culture?
Yeah, there's a number of people here I know that are part of large hospital systems, and they do present a lot of uniqueness when you're trying to build culture, but you have to have the same sort of philosophies across the system. We've got 100-bed critical access hospitals all the way up to 1,000-bed tertiary care hospital and a major academic medical center like Georgetown University. And so you've got to kind of blend those. However, we use the word systemness, which I think is very important, is across the system we have the same goals in quality and safety, same objectives, same strategic plan, same incentives and same drivers to make those things happen. And you've got to appreciate that there are differences, but you have to be aligned, and it's got to start from the top. I think, to the point of high reliability and Rick on transparency, those are so important. But I think two areas that are extremely important in systems, just like in hospitals, is leadership. You need a strong CEO in a hospital. You need a strong CEO at the corporate level of a system, and we've been blessed to have somebody like Ken Samet who runs our system across. He says if we don't get quality and safety right, nothing else matters, and he stands up there and really preaches that. He starts his board meetings with quality and safety metrics first before financials. Starts them with a safety moment. He elevates that and expects that across all hospitals in our system. He's amazing. I send a serious safety event report out every Friday afternoon of the serious safety events across our system to share the learnings amongst the hospitals. And he is notoriously the first one to respond to that email that goes out. And when there's good weeks, he's feeling good, nothing there. We play a little contest, a trivia contest to celebrate, and he's also the first one to answer the question. He's so competitive and stuff. The other thing I just wanted to touch on briefly was just culture, and we haven't really gotten into that. I think it's so important to really embellish that. Sidney Decker, who's somebody I really like, wrote a book about just culture, balancing safety and accountability. And so I loved hearing Clinton talk yesterday, President Clinton, when he said we've got to give people the feeling that tomorrow will be better, the hope that tomorrow will be better. It's Lucian Leape's Joy in Meeting and a whole message. And one example that we've really gone forward with is good catches. We celebrate, we reward, we embrace this good catch model. And every Monday morning, we send out the good catches of the week across the system. We pick 2 or 3, and we celebrate those people. It's called celebrating the behaviors you want. And we've got a luncheon in February. 100 people are coming with our CEO who have turned in good catches, coders, transporters, really doing great stuff and sharing that. I think it elevates that. On the other side, there's accountability. And I think if we aren't accountable as caregivers to those that we know are knowingly violating safe policies and procedures, those that are disruptive in their behaviors. I came from a previous facility where when we started monitoring disruptive behaviors, 11% of the disruptive behaviors of physicians was categorized as temper tantrums. I don't know of any other industry that would put up with that. And I think we owe it to our patients to stand up and be accountable and to call the shots when we need to.
Dave, that's such a great point. I want to pitch this to our other panelists about just this general notion of the balance between sort of blamelessness and accountability, and how you have reached the right balance, or do you think you're still striving for that right balance? Please don't be shy.
I'll take the first swing. So I think you can't just be a blameless culture, because then you get too far to that one side and nobody's accountable and nobody's responsible. So, we have an algorithm that we follow, that we work through when we have events, gives consistency. We're still working there. I mean, I don't know that we're the shining example. I know we still have work to do, but we're certainly not going for a blameless culture. We're trying to get a fair and just culture that everybody, physicians, nurses, everybody that's involved in any of these incidents gets treated fairly. The other thing we're trying to work in is the idea of a second victim, and that how do we reach out to those people who are not damaged like Laura's family, but also have impact in their lives too, and have that be more of and I'll use Clinton's word that he doesn't want to use, proactive instead of a reactive thing. But we're still working on those things.
Anyone else, Steve?
Josh, I just wanted to share something that I believe is related, and it's having a fundamental respect for the people that are working in our organizations. Along our long and arduous journey on high reliability, we've learned a number of things, but a few years back we came to an aha, in that we have the goal of zero. And essentially what that requires is that the thousands of people that work at our organization bring their A game and commit their A game every single day. And we found that we, perhaps as an organization, our leadership wasn't respecting them. And the aha we came to is that we realized that the healthcare workers that we were asking to keep these kids safe had an injury rate themselves that was 4 times higher than the coal mining industry. And that how could we as an organization ask them to commit to take care of these kids unless we figured out how to commit to have them come to work each day and go home safe. And so about 3 years ago, we ended up not having patient safety or employee safety. We made it safety, and that putting equal emphasis on the patient safety portion of it and the employee safety, because we just believe they're so inextricably linked that we need to show as an organization we are committed to you so that you can commit to these kids.
That is a great point. Rick, did you want to?
Josh, I don't think it's as complicated as we make it, but it does hinge on clear communication of expectations by leadership especially, filtering all the way down, and then consistent behavior around those things. So if you communicate certain expectations in your OR, but you have a surgeon who, as has happened at our institution, has a lot of NIH grants, and we happen to tolerate his tantrums because he seemed to be the fair-haired boy, that destroys any attempt to create that culture. So that clear communication of expectations and then consistent enforcement of it makes these things a lot easier than we might think.
Yeah, we have that an algorithm for just culture, and at first, we'd get into a meeting and we'd disclose an event, and somebody would be all ready to point a finger, and then we'd pull out the algorithm and go through it, and it's almost always the same parts of the algorithm, and it gets down to some organizational problem, almost always. And over time, you don't have to pull out the algorithm anymore because people stop, they don't first thing say, why is this person responsible? After a while, they know that it's probably an organizational problem, and we hardly ever need to pull out the algorithm anymore. That just changes over time.
I think that a general theme is this notion of a consistent message and then actually doing what you say you're going to do is so important to create that sense of culture. Before you answer, Coleen, I want to direct a question to you around disclosure. So clearly part of patient safety culture is talking to families when something bad happens. Can you talk a little bit about what we know about the best way to do that?
I think one of the most powerful things that we can do as caregivers for families and patients when something bad happens is to just start by saying, I'm sorry. And I don't think that really happens very often in a way that it should, and that it would really help. And then involving the family and the patient, if possible, in trying to figure out what happened and how to prevent it from reoccurring. And so that disclosure is just a plain statement of facts. It's not interpretation or opinion. It's here's what we know, and we're going to tell you things as we find them out. I'm a caregiver and a healthcare professional, but I'm also a family member. And my father-in-law, he suffered a fall in a hospital at which my father was an attending physician, and in the same system. And he suffered a brain injury, and he eventually died because of it. And it was probably 8 or 9 hours after he fell that anyone came to talk to us. And that just wasn't the right way to do it, because we had questions and we felt marginalized. And even though I knew the questions to ask, the family didn't. And so I think that that's really important to disclose right away. We understand what happened, we understand this fall occurred and this brain injury occurred, and we're gonna find out for you what happened.
Actually, that's a great lead-in, Laura, to what the work of your foundation. Maybe you can talk a little bit about how.
Right, when my mom was in the hospital, one thing that did happen before the good happened was that, if we did start asking questions and the risk management came down to our room. Nobody else came down to our room, it was the risk management at first because they were, they're nervous. And, but then, that all went away and, obviously, we worked so closely with the hospital and the CMO and the president, and we have a wonderful relationship now, but it was very healing to actually be able, I think on both sides, to be able to share my feelings and for them to say they're sorry and to share their feelings and to work together to have a solution. And it is very healing. It was so healing for me to be able to do that. And I feel so sorry for other families and other families that come up to me and tell me their stories, and they are so upset, and you can see that they are still, they hold on to so much because they never got that chance to have that kind of interaction that I got to have. And I think it's so important to be able to, not worry necessarily about the risk management coming in the room. Just, it's okay to say, I'm sorry. It's huge. After, and if it's okay to talk about what we did with the foundation. I always think to myself, my driving force is if I could only have 6 hours back, what I wish I would have known, what I wish I could have done differently to save my mom. And I looked everywhere, all over the internet, because I was like, I didn't ask the right questions. I was like, well, there's got to be somewhere out there that tells families and patients what questions to ask. I've seen campaigns and things like that to say, speak up, or you always hear, you did hear, doctors and nurses always say, please ask lots of questions, but you have no idea what to ask. A doctor comes in the room and said, do you have any questions? You're like, oh my God, I don't know. I'm nervous. I have 20 questions, but then I can't remember any of them. And so I looked, but I could never find anything on the internet. And I was like, okay, well, this is what we're going to do. We're going to create a guide that kind of gives you that roadmap or that playbook to help you through your whole hospital experience, so the families and the patients, know what questions to ask before, during, and after your stay. And it was an amazing journey. We worked for about 1.5 to 2 years, and we brought in doctors, nurses, patient safety leaders from across the country. And it's neat because we have some here today, Dr. Michael Shabbat from Texas and Helen Haskell. We came together and we created this guide, and we took that language, because all of you know, all the doctors and nurses know that you speak your own language. It should basically just be Chinese or whatever, because we just don't, patients and family members don't understand what it is. So how do we take the language and dissect it and create questions to help, the family go through and ask these questions? And it was really, really an amazing experience. I think after we finished, the guide, and I was talking to, we had a conference calls and emails, and I sent a huge email out to all of the contributors to the guide, and I was like, it's so amazing what everybody's doing every day in their own specific field that they work on so hard all the time. But it was this neat guide that we've created with, that helps, in all these areas that we were talking about today: infections, medication errors, falls, bed sores, all this kinds of stuff that people are working on to try to improve. And I said, individually, you guys are making such a difference, but together, I think we can change the world. And and we love what we created, and we have it now in a guide. We have it in an app for your iPad. We have it in Spanish. We've started creating the drafts are done for the pediatric guide, for a transplant guide for patients, and it's amazing. I love it when I get the thank yous. I mean, we get so many thank yous from families. Thank you for helping me, be a better parent to my child, that we caught a medication error that, we didn't know about. And it's that kind of stuff. But we just want this tool to be a teamwork tool. It's really that bridge between the family and the patient and the staff. It's really, it kind of breaks down the barriers. And that's what's really exciting, because, like I said, we just want to help you and to be part of that team. And I think creating these kinds of tools, whether it's us or other people, to help make that bridge, I think is so important to changing the culture. And I always kind of sometimes I think, I'm a competitive person by nature, but I was like, there's no reason. I was like, Susan G. Komen has done amazing things, the breast cancer awareness, and she saved thousands of lives. And I was like, there's no reason what we do, preventable medical errors, it crosses every disease. Not everyone is touched by this. And I was like, there is no reason with what we are doing here that we can't have that awareness, that everybody knows what this is and we want to do something. And I thank Mr. Kiani for doing that and bringing all these people together to start this movement, because I really feel like it should just become second nature. That's what I feel like it should be. And I have this, I love it because Dr. Shabbat, I'm so glad he's here, because he was like, we have inspirational quotes in here, and he's like, Laura, I love this quote. Will you put it in the guide? And I was like, oh yes, and it's the first quote that I have actually when you open up the page, and I think this is perfect for what Mr. Kiani has done in the movement that he's created. And it says, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." Margaret Mead. And that is so true.
Thank you for sharing that, Lauren. Thank you for the work you're doing.
I just want to make a quick point about disclosure. We make actually all the news stories about the University of Michigan's program talks about the malpractice savings, and yes, there are those. And there is, to be sure, the human decency part of it. To not circle back and loop back in with the family is simply indecent. But there's a selfish part of this. We cannot create accountability unless we are willing to do those disclosures. And they don't always go well. You can't expect a kumbaya Disney hug because as you tell somebody that you made an avoidable medical mistake and their lives just changed. But you do it because it is absolutely essential to creating the accountability that we need to improve going forward.
That's an excellent point. I saw lots of heads shaking as well. All right, in our remaining couple of minutes, I want to just talk about some specific innovation. So, Marty, you actually have worked with the Joint Commission Center, and maybe you could talk about a couple of the things you've done to change culture.
Yeah, we were part of a group of hospitals that worked on a collaborative with Coleen and with the Center for Transformation around culture of safety. And what we started to focus on, and kind of is a barometer of your safety culture, is your voluntary incident reporting. And we worked with one of our hospitals in our system, one of our smaller hospitals in our system, and with their labor and delivery department, had some really learning moments that from there that we saw, and then we saw some back at the larger medical center. But at the labor and delivery department, we were trying to figure out, like what can we do to improve our reporting? And you have the usual things: it takes too long, nothing ever happens, the usual sort of thing. So we said, okay, well, let's start I don't know what to report. So we kind of started focusing on all those. But the first big aha we hit was nothing ever happens. And we got reports back from doctors, from obstetricians, and from labor and delivery nurses, and from surgical nurses, because this was a small labor and delivery service. Emergency C-sections had to be moved into the OR to occur. They didn't have the ability to do that. And everybody was frustrated with that, the obstetricians, the labor and delivery nurses, surgical nurses. So we started working on that and brought those nursing units together, figured out a checklist for an emergency C-section, figured out a mentor system so that the transition from the labor and delivery into the emergency C-section, that same nurse could participate and be part of it. We cut that the decision to incision time down to about 18 minutes, and physician satisfaction went up immensely, and confidence went up immensely. Once we saw that happening, we started seeing our incident reports started coming up equally as well. The other thing we did at the medical center, which is the large academic medical center, 1,000 beds like a lot of your places here, is that we started what we call a daily safety check-in. And a lot of you probably have these daily safety huddles where you talk about what happened in the previous 24 hours, what concerns do you have immediately, and what are your anticipated needs in the upcoming 24 hours. And we started it, and we got what issues did you have in the last 24 hours? We got, we were fine. So after about 3 days of we were fine, nothing happened, I said, well, so that would mean that you put in no incident reports. And they're like, no, that's not true. So then I said, well, tell me about your incident reports. And what happened over the next few weeks was, as we built this trust and transparency around, we weren't going to go after the person who would file the incident report. We would come back and say, okay, well, what can we do to build you a better system around that? And after about 3 weeks, we saw our voluntary incident reporting at the medical center go up about 40%, 40%. So it all kind of ties into that trust and transparency and having to build that culture of safety. Those are just key, along with respect, and Steve was saying, I think those are just those key building blocks that you have to have.
Yep. Incident reporting is another tool that has to sit inside a culture that supports safety. Otherwise, it'll just be a wasted exercise.
Exactly.
So, Dave, maybe you could talk in a minute or two about the Educating the Young program, very innovative program to sort of change the evolution of mindsets about safety.
Sure, I'd be glad to. I really believe, as do many people, that if you look at how aviation did a lot of their work and other high-risk industries, they started really at the first day of what they called acculturation into the field. In fact, Robert Helmreich and David Muething in front of the IOM said that's exactly what you got to do. You got to start at your student level and start indoctrinating safety and quality in at that level, nursing, pharmacy, multi-professionals, and move it on. So in fact, this will be our 10th year anniversary, started the Telluride Roundtable and Patient Safety Summer Camps, and we've been blessed through great funding and support through the years that this year will be our 10th year. Rick's been faculty. Many of the people in the audience have been faculty out at our events. We do them now on the East Coast as well as Telluride, Colorado. We will be bringing 125 to 130 medical students, nursing students, pharmacy students, and then in separate sessions, resident physicians to engage in a deep week-long immersion. These are students and residents who apply from across the country. We get about 3 to 4 times the applications, but we insist on a background in leadership and a passion in safety and quality that's been demonstrated either through IHI work or other work. And over the last 5 years, we realized, as you've heard throughout this session, that the 800-pound gorilla in the room is transparency. And so we spend the majority of the week around transparency, shared decision-making, informed consent issues, end-of-life issues, disclosure around medical errors and early communication type programs. What we did starting 10 years ago, and it has been the best thing we ever did in regards to the events, is we brought patients and families into the conversations with us, and we brought them out as faculty, and they sit in small groups with students and Rick and others, just engaging in how to go after this. And it's been amazing to see that as they go into their latter careers, they are now leading a lot of quality and safety projects. IHI, a number of them presented this year. Many people may have seen work that they had started at Telluride that's made a difference. So it's been pretty fun to watch. And as Rick will vouch, I'm sure it is inspirational. I go back, recharge to to face some of the day-to-day things that we have to deal with, which aren't fun at times.
That's a great point, and maybe Steve, you can take us home with that. Picking up on that notion, one of the hardest things to do in improvement is to sustain improvement. That we'll leave this conference, we're energized, we've got some ideas. How do we as individuals and how do we as a sector keep this effort alive and going strong?
Well, I appreciate all the panel said, because it's essentially keep this up forever. And I think to some degree, it's an acceptance of that our job, if we've chosen to be leaders in healthcare, part of that job is a constant state of unease. And we have to take care of each other. We have to deal with it. We can't let it weigh us down to the point where we're not functioning. But with the great honor that we've taken on to be able to work with families and patients, we have to accept that this is just part of the burden. And whatever our role is in an organization, we just have to accept that we have to have that constant state of unease. And we have to be relentless. There's going to be good days, there's going to be bad months, there's going to be good years and bad years, and you have to be relentless. And when it's looking dark, you just got to keep believing that zero is possible.
I think that's a great answer. I don't know if that helps us get to 120 years old, but it's probably the
Maybe
right
not.
answer. So let me thank our panel for a terrific discussion.